Getting back to this issue of STI, and yesterday, the woman in the fourth row, you asked a really great question. I want to ask, just by showing of hands, if you're willing, how many people in this room have actually been offered a rectal swab for STI testing in the last 12 months? Offered a rectal swab. Okay, so maybe more than half of the people in this room have been offered. Now, how many people in this room recall ever getting offered a rectal swab prior to November of 2007, prior to 10 years ago, by show of hands? Okay, one person? Only one person in this room was offered a rectal swab before 10 years ago. That's really telling, and I really want to point to your question from yesterday, and Darrell, from your research and what you were just sharing, because what happens when we take a neglected population and start to deliver adequate health care and rectal swabs to people who were never getting them before? What happens is you're going to see a lot more STIs than you did 10 years ago, hence part of why we see those numbers going so high on all these charts. But what we're learning, and what Sheena McCormick from the Dean Street Clinic in London is showing us, and the work of Samuel Jennis is showing us, is that when you start to finally deliver STI services and adequate STI testing and treating to people on PrEP or people at risk for STIs, you will see a spike, and then it's going to start coming down because you're finally giving people adequate care. And that still needs to be seen in more data, and that still has, on rare occasion, been measured against a control group. But my whole point here is that correlation is not causation, and we don't want to conflate those two. When we're going outside of this conference and talking and dealing with these questions about STIs, correlation is not causation.
Thanks, Damon. Josh, did you have a question?
Yeah, just super quick. Actually, kind of more of a thought, Nate, specific to our work with the Get Prepped survey. I think that maybe some of
our
the...
work, Josh.
What's that?
Our work.
Our work together. I think some of the overestimation of prevalence could be... I see not enough dialogue within our community about our sex lives, and especially our sexual health lives. And I think that within some of the apps and hookup sites, when we see things like being able to put as your own, preventative measures like TASP or PrEP, those are great. But those can also be kind of like a shortcut to actual conversations. And I think that personally is something I see as happening, is that there's just an assumption that we no longer really need to talk about sex lives. And that trickles over sometimes into like desires and all of that stuff. So that would be one thing that I would say, is just that people aren't still talking enough about like what they're doing, what they want to do. They're more comfortable having sex than talking about sex. So that's it.
Yeah. I mean, one thing that's a little different that I've realized in how we asked the questions was, how many guys do you perceive in Vancouver to be on PrEP versus how many of their social network they knew were on PrEP? So I think that does highlight your piece around how much guys may be talking with the people they know or the people they're having sex with around it, which I think is important for us in terms of thinking about community strength in how we support and take up this new tool.
Diane?
I just have a comment, sort of. As I'm work on the grassroots doing STI HIV testing, and it took a lot of energy from the grassroots to get rectal swabs offered because of the cost, the routine cost. So when we talk about comprehensive, collaborative, preventative work, the labs have to be on board in your particular organizations, and it does take some advocacy from the ground to get that happening as a routine thing. And luckily I work in BCCDC, and we do offer that now routinely as part of the screening, which it shouldn't ever be a questionable thing now. We know that about gay men's healthcare. And I have to say, just from that point, I don't have any data on it, is that since we began detecting infections early, the consequences of those infections are less. It all really works together.
Thank you. And Sheena McCormick from the Dean Street Clinic does have data to exactly support what you're talking about. So thank you.
Well,
yeah, we've seen a couple of slides this afternoon and this morning showing research that if we take PrEP 4 times a week, it works just as well as taking PrEP 7 times a week. Yet I've only really heard discussions about 2 ways of taking PrEP, either on a daily basis or on an event-based basis. In London, we're starting to develop a way of talking about a third way of taking PrEP. And I'm sorry, this only works for the English language, but that's the way I take PrEP, which is called the 2 T's and the 2 S's. So Tuesdays, Thursdays, Saturdays, and Sundays. And I wonder if any of you have kind of considered this as an approach you might talk to people more about, particularly because it might help to diminish some of the renal side effects, but also it helps to stretch out a bottle of PrEP for much longer, particularly for people who are finding it hard to afford to buy a bottle.
I've had conversations about that with clients in clinic. It's come up in the context of my patients who had PrEP covered through Blue Cross being quite abruptly cut off from their coverage for PrEP, and these clients looking for ways to stretch out their supply for as long as possible until they're able to secure some other pathway to access PrEP. But yeah, I haven't seen really any data on that other than what Dr. Tan has presented. So I usually send those clients to someone like Mark.
So interesting. All I'll say is that, so certainly I've never recommended that to anyone, and I think part of it is sometimes in this world we feel so conflicted between what's my responsibility to an individual patient in front of me. I want to give them the best possible advice that I can based on the best scientific knowledge that I have available to me. And I think, I like that traffic light colored slide that I showed earlier because it looks so encouraging around how effective PrEP might be in GBMSM with imperfect adherence. But I always phrase it, I will admit, I always phrase it in terms of this supporting the idea that PrEP is much more forgiving. We all, I think a lot of us talk about it this way, but it's more forgiving of imperfect adherence, than, for example, ART is. And I always point out that, the people in that study were intending to take it every day, right? And so what ended up happening in their lives was they took it only 4 to 6 times per day. The Réjean this morning talked a lot about, why is it that uptake of the on-demand strategy seems to be centered in France and Quebec and not really in the Anglophone world, and identifying that as potentially a problem. It might be a problem, but it might also be a reflection of people's hesitation in the face of incomplete data, right? There's a confidence interval around that estimate of 100% efficacy when people are taking 4 to 6 doses per week. There's not as much data on on-demand PrEP, and we just don't want to do a disservice to the individual in front of us who might be that, part of that 14% that is maybe at a higher risk. And so it's, I don't know, it's fascinating. You're making me think a lot, but oh yeah, sorry. And the last thing I wanted to say was that another reason I wrote a little editorial beside the open label extension of the EPRGay study in the Lancet recently, where I was talking about how what would be the reasons that people might want to take on demand, and you alluded to some of them. But I pointed out in it that the authors of the EPRGay trial, in their introduction to the original paper and in the follow-up, they say one of the reasons we wanted to study this regimen was we thought that adherence with it might be better. And it's interesting because I don't know that the data support that, right? In fact, the adherence in the open label extension of the EPRGay trial wasn't all that good. Only half of the time were people taking it properly. And there's other randomized studies that have been done in different settings around the world, led by the HPTN, where they directly compared adherence with intermittent versus daily schedules. And actually, it tends to not be better. So lots of challenges, but really interesting.
And Will, the only hesitation I personally would have is that, like you said, we just don't have the data. And it doesn't mean it's wrong. It just means, for me, the peace of mind is really important. So I personally would not have peace of mind with that regimen, but maybe others would. And like you said, there's the data, we could extrapolate that from the data and say it will work. But I personally, having gone through what I've gone through, would not feel peace of mind with that.
Okay, we have time for one last question before the break.
So this is a comment towards the Davie's Buyers Club. So in your process that you describe in terms of procuring PrEP as well as taking it, as well as how to take it every 3 months, and I find that the whole process kind of underestimated the rules of other healthcare professionals, which basically work together for collaborative care in terms of safe medication dispensing, therapeutic drug monitoring, Because as myself as a pharmacist, I find that we do have a very important role in terms of like monitoring drug interaction. Because when you think about like PrEP users, because there's no specific age cohort, whether or not it's going to younger people only taking PrEP, or there's older people, there is no specific age group to it. So I feel like there is definitely like completely like a huge variety, like huge range in terms of people's like multi-comorbidities. So some people have multiple medical conditions that may not be addressed or necessitate like numbers of medication. And I feel like that could be easily missed if someone bypassed the need of pharmacists to basically identify any drug-related issues, which may contribute to like, even though improve sexual health, but also lead to like negative health outcomes as well. And also that just does not limit to pharmacists itself, but there's also other healthcare professionals that could be very easily integrated to the process, which is like mental health therapists, as well as like even social worker as well. Because I feel like right now our care, it's like, at least what we've talked about during this conference, it's very focused on prescriber being basically just the prescriber as in a medical doctor or a nurse practitioner sometimes that you guys mentioned. But there's also like, there's tons of prescribers as well, including like in Alberta where I'm from, we do have like additional prescribing authority where we can prescribe for any Schedule I medication, including Truvada. And we have extremely like capable HIV pharmacists in the Northern and Southern Alberta program who initiate therapy for HIV infection, but they're definitely capable of also prescribing for like Truvada, like for pre-exposure prophylaxis as well. So I feel like, I mean, it's a great initiative, great project in terms of procuring access for people who lack the means to do it, but I think that it also preludes like the rules of other healthcare professionals providing this multidisciplinary care for people.
Thank you for that comment. I think that's a reasonable concern, of course. My website, the first thing it encourages people to do is to connect with a provider. So the intent of my website is not to bypass other healthcare professionals or the healthcare system. The goal of my website is to simply meet the needs of clients where the healthcare system fails them. I'm very explicit on the website that PrEP still needs to be prescribed and monitored by a competent provider, and I would hope that people accessing prescriptions for PrEP, regardless of where they fill their prescription, are able to access appropriate care and monitoring. And I do feel a bit of a safeguard in that, it was my concern as well that people not be sort of accessing PrEP, without a prescription, without monitoring, because there are some important safety and efficacy concerns. And it's somewhat of a safeguard is that although some websites allow people to order medication without a prescription, one definitely needs a prescription to re-enter Canada with their medication. So that is somewhat of a safeguard. Ultimately, I think your comment about involving pharmacy in this is a very valid one, and one that I think that I will include on the website, that if people are accessing their medication, their PrEP, and if they do take other medications, that informing their pharmacist of drugs that they have accessed elsewhere is an important component to this process. So thank you.
Yeah, thank you. In a perfect world, we would all have access locally to a caring, compassionate provider who would really get to know us holistically, our mental health, physical health, know about our lives. And when people have that, it's such a beautiful thing. But unfortunately, when people don't have that, or they don't have access to that, or they have no other way to get PrEP, I think Alex and a lot of the online pharmacies provide a really necessary service, and it's harm reduction. It may not be perfection, but it's harm reduction, and it's invaluable in this fight against HIV.
Okay, unfortunately, we've run out of time for today's session. I don't want to eat too much into the last break of the day. We'll be convening again in about 10 minutes or so, just over 10 minutes back in here for the closing session. Thanks.
Thanks, everybody.